Hello, friends. Sol here with the new CKD guidelines that just came out a couple of weeks ago in March 2024, the 5th edition. And the idea is to go through the highlights of this new one together over the next, let's say, 40 to 50 minutes. So I only try to cover the highlights. There is a bit of a change in the new version. The changes are not a lot, but they are very important. They are about the topics that you cannot afford not to be aware of. And we go through those together in a minute. What I really like about CKD guidelines, and to be honest, this is probably my most favorite Australian guidelines. It is right to the point. It is practical. Doesn't really leave many gray areas. It's all black and white with the instructions, step by step, and makes it very easy to follow and to diagnose and to screen first and diagnose and then manage all different stages of CKD. So I really love this one. And I hope that you guys enjoy learning from it and also putting this into your daily practice. What we learn from the guidelines is the definition of CKD. Why is it important to screen for CKD? What is the advantage? What are the risk factors for CKD that we need to look for so we can decide on screening? How to screen, or basically what is kidney health check that we need to run on patients with risk factors? What to do when you diagnose CKD and how a good GP manages CKD. This new guideline is really empowering us to manage CKD by ourselves as competent GPs in our practice. Once you read the whole thing, the whole idea is about making CKD a general practice topic and not a renal physician sort of presentation. Yes, we do rely on renal physicians at certain point with certain patients, but majority of CKD patients can be managed in-house by us as good GPs. Obviously, we're going to learn about the referral criteria for CKD to specialists. On top of the usual stream CKD, which is about eGFR and albuminuria, we cover microscopic hematuria management. Sometimes it's related to renal causes, and sometimes microscopic hematuria is related to urological causes. So we cover both grounds. Hyperuricemia and gout is covered, as well as kidney cysts and polycystic kidney disease. And we touch on kidney stone management in general practice and prevention of kidney stones as well. So the 5th edition emphasizes on most important new medications that we now have to play with and then to reduce the progression of CKD. There are important medications now out in this field. There are some changes in the diagnosis of CKD. The definition of microalbuminuria has changed, and it's easier now to learn because there is no difference between men and women anymore. There's only one number to remember, which is good, or two numbers, 3 and 30. The new CVD risk calculator and the guideline recommendations have been incorporated in the new CKD guidelines. The referral to specialists is a slightly changed. Majority of the referral indications are still the same, but they've just changed the look of it. And again, there are certain minor changes on how to reduce the rate of albuminuria and with more specificity of what the target is and what medications we can use. So we're going to cover them all in the next few minutes, or let's say 40 minutes. So definition of CKD, two different things. One is about the filtration rate, the main function of kidneys. If the eGFR, estimated GFR, remains below 60, we like to check it again for, within 3 months. If it remains below 60 for a period over 3 months, that is one criteria for CKD label. Sometimes you may have fully functioning kidneys with good filtration rate, but if you have some other evidence of kidney damage, like albuminuria, hematuria, which is not related to urological causes, structural abnormalities found otherwise, like polycystic kidney disease on imaging, or someone who, for other reasons, like for familial reasons, for example, happen to have a biopsy of the kidney tissue and diagnosed with CKD, despite having a normal eGFR, they still carry that CKD diagnosis for the rest of their life. Remember, you can't wait for signs and symptoms of CKD to appear before you diagnose CKD, because that usually is very late. You need 90% of your kidney tissues lost before you diagnose someone, before you have symptoms and signs of CKD, which are listed here for you on the screen. More than half of the patients with CKD in Australia develop CKD because of diabetes or because of hypertension. About 1/5 have CKD because of glomerular causes. Some, about 7%, not a lot, are familial and hereditary. And about a quarter are caused by other things, like by lupus, connective tissue disorders, some tubular interstitial diseases, which we don't necessarily need to be aware of all, but that's the other 1/4. Next two slides are very important because it really explains why, for us as GPs, is important to learn about CKD, to screen for CKD, and to manage CKD. Amazing, or not, maybe not so amazing, maybe shocking numbers I'm going to present to you from the guidelines. Remember, CKD is twice as common as diabetes. That gives you an idea of how many CKD patients you should have in your practice, and maybe how many you have not diagnosed yet and you should have. 3 out of 4 Australian adults have at least one risk factor for CKD. 3 out of 4 of Australian adults have at least one risk factor for CKD, which means they need to have kidney health check on regular basis. 1 in 10 Australians and 1 in 5 First Nations Australians, again adults, live with signs of CKD. If someone has CKD, the chance of dying from a heart attack or stroke increases by 20 times. So the main reason for screening people for CKD and treating is not just to prevent dialysis and kidney loss. It's more important because we are going to save patients from cardiovascular disease and death. 20,000 people die from CKD every year in Australia. It does have a lot of impact on the health system, on the well-being of our patients and the families and the workplaces. So it is extremely important to diagnose and manage CKD. Next slide shines a bit more light. With the new treatment options that we have, we can slow down the progression of CKD by 15 years. That's a lot. And if the CKD is detected early enough by us, proud, empowered GPs, we can reduce the progression of the disease by 50%. Another shocking number, less than 10% of people who do have CKD, less than 10% of them are aware that they have CKD. That's shocking. I can't believe this number. 1 in 10 is aware that they have this chronic disease that puts them at so much high risk of developing cardiovascular disease and long-term kidney disease, and makes them ineligible to receive some medications, or they should avoid certain nephrotoxic medications. But 9 out of 10 of them are not even aware that they have this condition. Whose fault is it? I don't want to blame anyone, but that again makes this guideline an important one to learn and to act on. Let's look at an MCQ, which has more than one answer. We like to know which of these patients is eligible or is required to receive kidney health check. A 22-year-old smoker, a 49-year-old Aboriginal, a 19-year-old obese with BMI of 34, a 55-year-old who has some stents put in the coronary arteries, or a 63-year-old with mild hypertension and nothing else, who requires regular kidney health check? The answer is all of them. They all require regular kidney health check, because anyone who's got the risk factors on the left-hand side, diabetes, hypertension, cardiovascular disease, family history of kidney failure, BMI of over 30, anyone who smokes or vapes, anyone who has had an acute kidney injury in the past, anyone over age of 60, anyone over age of 60, or any First Nation Australian over age of 18 requires to have a regular kidney health check. What is kidney health check? Kidney health check is the combination of 3 tests: blood pressure, which we prefer a combination of in-clinic blood pressure measurement, but also addition of ambulatory 24-hour blood pressure checking and home blood pressure monitoring, because those two are more accurate than the in-clinic blood pressure monitoring. So one is BP, 2 is urine test for urine ACR, albumin creatinine ratio, and the third one is your eGFR, estimated GFR. The 3 of them makes up the kidney health check. A beauty of this 5th edition is that they give you a more concise and straightforward advice about how often we need to run kidney health check. People with diabetes and hypertension, we have to do it every year. People who have established cardiovascular disease or family history of kidney failure, or obese, or those who smoke or vape, every 2 years is the minimum requirement for kidney health check. Those who are over age of 60, they need to have a one-off kidney health check. If that comes back normal and there's no other risk factors, we can leave them alone. But as soon as they develop a risk factor out of that long list, then we need to put them on regular kidney health check. Anyone who had an episode of acute kidney injury, for the first 3 years after that acute kidney injury, requires to receive annual kidney health check. After 3 years of annual, we can put them on every 2 years kidney health check. Remember, COVID-19, and particularly we're talking about long COVID, is now a potential risk factor for long-term CKD. It's an emerging area. But what we know is that if someone has developed acute kidney injury as a complication of COVID-19, which kind of falls into the AKI or acute kidney injury anyway, they need to receive monitoring for CKD in longer term as well as those who have developed hypertension in pregnancy, either just a hypertension in pregnancy or gestational hypertension, or in a form of preeclampsia. They all need to be monitored with the kidney health check as well. Remember, with the kidney health check, when we talk about urine ACR, we prefer the first void because that's more accurate. But if that's not possible, a spot urine sample for ACR is also acceptable. Let's move to the Aboriginal or First Nations Australians. Like we said, if they are child under age of 18, they only need to be screened for red flags. They don't need to receive kidney health check. As soon as we find a red flag, then they need to have kidney health check with the 3 components. As part of red flags, we also need to add the low birth weight and recurrent childhood infections. Family history of CKD also counts as a risk factor. So if there's a child, the First Nations Australian with family history of CKD, they still need to receive regular kidney health check. As soon as they become an adult over age of 18, every First Nations Australian requires to have annual kidney health check for the rest of their life. And you can incorporate that in your annual health assessment as part of the 715 assessment for Aboriginal and Torres Strait Islander patients. There's a lot of advantage in screening people and doing kidney health check. Like we said, it helps people to avoid nephrotoxic medications. It helps them to have a 6-day action plan with the SATMANs, which we're going to cover very soon. Helps us to adjust the drug doses. It helps us to introduce medications that can slow down the progression, we said by up to 50%. And there is a huge economic advantage once we screen the population properly. When I say we, I mean you and me in our general practice, and find CKDs early on. Let's talk about the let's say 2 out of 3 components of kidney health check. Blood pressure is obvious. With the eGFR, it's the best overall measure of kidney function, the filtration rate. It's not, the creatinine is not your alternative in general. Creatinine is not sensitive. Creatinine only goes up if you have significant kidney damage. At least 50% of kidneys should be lost before you start seeing some creatinine rise. And remember, with the eGFR, 90 is the cutoff for normal. But if the eGFR is above 60 and there is no proteinuria or any other reason to put the label of CKD on the patient does not receive the CKD label until the eGFR drops below 60. So between 60 and 90 is a gray zone. You wait for another reason to label the person with CKD if the eGFR is between 60 and 90. Normal is above 90. Under 60 by itself is a reason for CKD, like we discussed earlier. Between 60 and 90, we need another reason to put the label of CKD on the patient. And that is explained again on this slide as well, the 90 and 60, the difference between the two. So with the eGFR, we're still talking about eGFR, even though it's a very accurate indication of kidney functions, it can be unreliable and misleading in certain situations. The certain situations could be physiological or laboratory variability. If the eGFR is above 90, any value above 90 is not very accurate. So there is no difference between 95 and 105. They say after 90 just loses its accuracy. Consumption of cooked meat can impact the eGFR, same as dietary restrictions like vegetarian diet or high protein diet. Both of them can impact eGFR accuracy. As you know, eGFR is based on 1.73 square meters of body surface. So if someone's body size is extremely big or small, the eGFR becomes less accurate. If someone has high muscle mass, then that can underestimate eGFR. In children under age of 18, again, because of the body size, eGFR is not accurate. In pregnancy, we know it's not accurate. Certain medications like fenofibrate and trimethoprim can impact the eGFR number. In acute kidney injury and in people on dialysis, we don't like eGFR so much. We prefer to stick to our creatinine as an indication of kidney function. And in amputees or paraplegic people, because of the body size and because of the way the muscle mass works, again, the eGFR is not super accurate. So in pregnancy, again, we know that eGFR is not a recommended test to measure the function of the kidneys. So still, because we have no alternative, we still rely on creatinine in pregnancy to measure the kidney function. So that was the eGFR. Let's talk about the other component of kidney function or kidney health check, and that is albuminuria, which is even more important as an indication of kidney disease than eGFR. So as you can see, elevated urine ACR is a more common sign of CKD than a decreased eGFR, which is commonly missed. So if you just want to monitor eGFR and think you are monitoring someone's kidney function, you are missing on many cases of CKD who only present as or present with albuminuria. So that's why we need to even put more focus on albuminuria than on the eGFR. Like we said, the urine albumin level is highest in the afternoon. So that's why if we like to have consistency, ideally we like to have the first void of the day as the sample. Doesn't matter if it's fasting or non-fasting. It has to be just the first void of the day. And the 3 is the number 3 milligram per millimole is the cutoff for microalbuminuria. So for men and women now, luckily, we don't need to worry about 2 different numbers now. 3 is the cutoff for abnormality. Anything less than 3, we're happy. We don't use the dipstick to diagnose proteinuria. We use it for hematuria, but not for proteinuria. We don't use 24-hour urine collection to assess proteinuria. That's gone as well. So urine ACR is the way to measure amount of albumin, which is the main indication of proteinuria in kidney management or CKD diagnosis and management. There are certain things that can impact the amount of albumin in the urine and gives us inaccurate urine ACR, UTI, too much protein in diet, cardiac failure in the form of congestive cardiac failure. If someone is suffering from a febrile illness, heavy exercise in the last 24 hours, menstruation through contamination or genital discharge, and NSAIDs can also impact the amount of albumin in the urine. Let's have a look at the case. We have Gladys, 83-year-old woman who lives in an aged care facility, learning about the kidney health check. We decided to check her eGFR and her albumin level. The eGFR has come back at 52. Her creatinine is a bit high as well. There's no albumin in the urine at the moment, sounds like it. What do we need to do? The take-home message from this one is that, yes, we do see a lot of reduced eGFR in elderly patients. Do we call it normal or physiologic, or do we need to take action on it? Yes, even though it's very common, but recommendation from the CKD guidelines is that the impact on the person, impact on the cardiovascular and the kidney disease risk is the same no matter how old the person is. So even though we don't get as worried or excited if we see a reduced eGFR in an 83-year-old, but in terms of the actions we need to take and the flow chart we need to follow, there is no difference between old or young people. So the answer was we need to monitor her. If the eGFR remains low, below 60 for longer than 3 months, then she's got CKD and we need to follow the protocols for management of her CKD by putting her on same medications, doing the same lifestyle advice, and so on and so forth. Our second patient is called Donald. He's a heavy smoker of 52 years of age, learning about CKD screening in a smoker person who has a risk factor. You properly did the eGFR and ACR and blood pressure. The only abnormality you found was an eGFR of 54. How do you deal with this situation? This is the first time in the recent time Donald has had an eGFR and it's come back as 54. So flowchart and algorithms to be just accurate and to be safe, they recommend if you find an unexpected or if you find an accidental eGFR below 60, you need to repeat it within 7 days because they don't want us to miss on an acute kidney injury or acute renal failure in the population. So if you have an accidental or surprising eGFR of less than 60 in a person who is not, expected to have a low eGFR, we need to repeat it within 7 days because we may be dealing with a situation of acute kidney injury. So if in 7 days, the eGFR dropped further by more than 20%, this is acute kidney injury, most likely. This patient needs to see a nephrologist or go to hospital as a matter of emergency because we cannot afford to sit on an acute kidney injury. If the second one within a week is stable or not dropped by more than 20%, then we need to repeat the eGFR within 3 months, usually twice. And if we have at least two out of 3 eGFRs below 60, persistent over a period of at least 3 months, that is definition of CKD, unless we have a reason for eGFR, which most likely there is no other reason, it's CKD. Well, unless you have an inaccurate eGFR, like the list that we discussed in an amputee and, certain diets and the rest. So that was the answer for this patient, Donald. We need to have it repeated first in a week. And then if it's not dropped so much, at least twice more we need 3 samples at least in 3 months. And if at least two of them are less than 60, that's CKD. Our next patient is a respiratory physician who happens to be a heavy smoker. Interesting. You learned about CKD guidelines and kidney health check. You ran a kidney health check on Mike. His ACR is above 3, so he falls into the microalbuminuria category in here between 3 and 30. 30 is the macroalbuminuria cutoff. He's got a slightly elevated blood pressure, and his eGFR is not below 60, but it's not above 90 either. So it's 70, which is lowish in the presence of albuminuria. What do you do next? So it is a bit suspicious for CKD. This is the first time, though, he's having tests in the recent years. So he needs to have urine ACR repeated on first void samples within 3 months to confirm proteinuria. So we can't just put him into the CKD group yet, because this is the first abnormal sample. It might be just accidental, it might be just inaccurate, even though we have a high blood pressure and a not less than ideal eGFR, but that microalbuminuria needs to be repeated. Again, we need, as you can see on the flowchart, we need to have within 3 months, we need to have minimum of 2 abnormal results above 3 milligram per millimole to be able to put the label of CKD on the patient and add that CKD diagnosis into patients' active current medical problems in the history. So with Mike, we did repeat the tests at 6 weeks and 12 weeks. They remained consistent. So we now know that his eGFR is around 70. And we know that he suffers from microalbuminuria in his urine ACR. So as a result, he now has CKD. If you look at the table, which shows the staging of the CKD, he would fall into this into the stage 2 with the eGFR of 70 and microalbuminuria of 3.2. So now after 3 months, we can say, Mike, you do have chronic kidney disease. I need to add that into your medical record. Our next step would be to find what is causing CKD. Sometimes we can find out, sometimes we cannot straight away. Does it mean that if I don't straight away find the cause of his CKD, I should refer him to a renal physician to do a biopsy and advanced tests? The answer is no. The answer is no. If everything else is fine and we just picked a new CKD, there are only certain tests that we need to do. Sometimes following those tests, we can find the cause of his CKD, which in his case might be his blood pressure. We might already have the answer. But we don't have to send the patient to renal physician to order advanced tests straight away, because we like to know where it comes from. When you read the guideline, you will realize that that's not the case. We just need to do, once you have CKD stage 2, possibly hypertension caused, possibly we don't know, but we have that diagnosis now. Next step would be ordering a set of tests. They are told to us what we need to order, so we don't have to worry. We don't have to worry about missing something or missing some a diagnosis that might cause us trouble. As long as we follow what is given to us, we're going to be safe. What do you want to order? FB-UNE, LFT, fasting lipids and HbA1c, and fasting sugar. You want to check his uric acid. You want to order a high sensitivity CRP and ESR, because you want to see if he's got some underlying inflammation in the body, which may be suggesting an underlying connective tissue disorder. You want to check for RBC morphology in the urine, because if he does have some RBC in the urine, that would be in favor of some glomerular diseases, some background kidney problems. And if you find that he's got hematuria, microscopic hematuria, and albuminuria, which he already has, that then is a reason to refer him to a renal physician when you have both protein and blood in the urine. That is concerning for a glomerular disease, which a renal physician may be able to help him to prevent the progression of the disease. If it's only albuminuria and slightly under ideal eGFR, we don't have to involve a renal physician yet. We are competent to deal with his CKD as good GPs. Also, you need to add a urinary system ultrasound, let's call it KUB ultrasound, to look for any structural abnormalities, any obstruction, any polycystic kidney disease, and the rest. If you do all these tests, sometimes you have the chance of finding the cause of his CKD. Sometimes that cause may require him to see a renal physician. In some cases, everything comes back normal. We don't know exactly where it comes from. Do we need to refer him? The answer is no. We don't need to. We just start the CKD management plan and we continue monitoring him. We continue searching for the potential underlying cause. Sometimes we find it, sometimes we don't find it, but that's not the main concern. So we talked about the first line investigations to order for this newly diagnosed CKD patient or respiratory physician. In certain situations, if you have risk factors, you may also order second line investigations when you diagnose someone with CKD. What are the second lines on top of what we just discussed? If you have any reason to think about a connective tissue disease or pulmonary disease or glomerular disease like hematuria that we discussed, then apart from considering referral, you want to also include an anti-GBM, ANCA, ANA, ENA, complement 3 and 4, and ESR, which ESR you already had in the first line investigations anyway, so that's not an extra one. If you have any concern about hepatitis B or C or HIV, throw those tests in as well in the first line or second line, doesn't matter. And if you have any concern about myeloma, which usually affects older people, then you can check for myeloma as well with the serum and urine protein electrophoresis, like Benz-Jones protein and serum protein electrophoresis. And you can also add a free light chain ratio called FLC to your test to screen for myeloma. So this covers everything that you need to do for a newly diagnosed CKD case. And if everything comes back normal and you don't have any sign of concern like the connective tissue disorders or pulmonary or arthritis, then again, you are safe to just focus on management of CKD. We will monitor the situation. We will look for potential underlying cause that we are missing. But if you pass that safety net, you are safe to just focus on CKD and don't worry about what is causing it. We just need to deal with the CKD. So in summary, again, we look for risk factors for CKD. We order kidney health check. If urine ACR is abnormal, we know what to do. If eGFR is abnormal, we know what to do as on the algorithm. And then based on what we do, we either exclude CKD or we label patient with CKD and we put them in one of these boxes, the stages. From stage 1 to stage 5, based on the result of ACR and eGFR, the patient falls into one of these groups, and that has to go to our medical records on our best practice, medical director, whatever practice software you use. This has to be documented. This is more important than ingrown toenail 6 years ago and a repaired inguinal hernia 15 years ago, which I see more often in the patient summaries than the actual CKD, which is a lot more important for me when I'm managing a patient to know they have CKD, even if it's a low stage, because it impacts everything. It impacts ordering investigations, ordering CT with contrast, giving them medications. That is a lot more important. And it's the one which is missed in majority of patients with CKD in their medical records, in the past medical history, the active past medical history, which is shocking. If we know the cause, if it's due to diabetes or hypertension, we assume, and there's no test to prove this CKD is caused by diabetes, but it's all assumption. We've done all the other tests. The only thing that we know potentially might have caused this is diabetes. So we say due to diabetes, but there's no test to say it's definite diabetes and not anything else. So once we put that patient into any of those three colored categories, yellow, orange, red, then it could not be simpler than this. Honestly, it could not be simpler than this for us. And that's what I love about CKD guidelines. Next step, depending on the color, we know what to do for the patient. Anyone can follow this. It's simple. So if the patient was in the yellow group, you like to put in place measures, lifestyle and medication to slow down the decline in eGFR and to slow down the amount of albuminuria. And we have a target for albuminuria. We like to reduce albuminuria by at least 30%. So if imagine the ACR was 5, we like to reduce it by 30%, which is about 1.5. So we aim for the next ACR to be 3.5 or lower. We also like to pay more attention to cardiovascular risk. We like to look at the lipid profile, their sugar profile, their diet, their weight, their smoking, and everything that can impact both CKD and cardiovascular disease. We like to avoid nephrotoxic medications. We like the patient to be aware that they should avoid nephrotoxic medications like NSAIDs, which are over the counter, unfortunately, or not unfortunately, but in this case, unfortunately. And so much attention to lifestyle. And lifestyle is well explained in the new guidelines, exactly how much exercise, how much alcohol, what sort of nutrients in the diet to include, what to avoid. It's even better than the 4th edition with all the new instructions and recommendations for diet change and in general about SNAP, smoking, nutrition, activity, and what was the P? Can't remember. We'll find out. So if someone falls into the yellow group, you want to review them every 12 months. You want to do weight and blood pressure and smoking history. You like to run urine ACR, eGFR, UNEs, and FBE, which is above the kidney health check. You may consider, which most likely you will, checking for diabetes, hematuria, and lipids. You still continue, if you haven't found the cause of CKD, you can still continue the process of investigation for finding the underlying cause of the CKD. You see, you've already diagnosed, you already put the action plan in place, and you are still searching for the cause. And that's not something to stop you and say, hey, you need to go to renal physician. Lots of attention to cardiovascular risk assessment and management. To slow down the progression of CKD, we like to use our medications. What options do we have? The top one is ACE inhibitor and ARB. They will reduce the amount of albuminuria. They will reduce the progression of the CKD, and they are the first-line medications that you want to throw in for any patient with CKD, starting from yellow, going to orange and red. Nowadays, we know that SGLT2 inhibitors, that's a new addition to the CKD guidelines. They can have the same benefit as well. So we like to add those if needed, particularly if you're not achieving the result. And there is certain medications, again, called non-steroidal MRAs, which we're going to explore further. They are, again, options to utilize. We most likely like to consider statins. And in women in childbearing age, we like to have a chat about pregnancy and contraception, because that is something that can potentially impact the progression of the CKD as well. And we like to put vaccination recommendations in place for the usual stuff, influenza, pneumonia, COVID, and shingles that you're aware of. Let's have a look at the case. We have Harriet Jones, 65, You diagnosed her with stage 3A CKD following a persistently low eGFR of 50 with normal urinary ACR and a blood pressure of 130/80. You put her into the yellow category of stage 3A CKD. And as you've learned that ACE inhibitor is gold to slow down the progression of the disease. And we like to not only start ACE inhibitor, but we like to increase the dose of ACE inhibitor to maximum tolerated dose, because that's where the most of the advantage happens. So you did the right thing by putting her on perindopril, ACE inhibitor, 2.5 milligram as a starting dose, see how she copes with the side effects. The question is, when do you need to see her again? What tests you need to order? What happens to potassium? What happens to eGFR after you start someone with CKD in particular on ACE inhibitor? What if her eGFR drops from 50 to 44? What if her eGFR drops from 50 to 34? When do we need to start worrying? We started ACE inhibitor because we didn't like her eGFR, and now we've reviewed her after starting perindopril, and her eGFR has gone even lower. What should I do? We're going backwards. Do I need to worry? Hey, renal physician, stuck as a GP, or we have something to follow? We do have something to follow. It's simple. And what is the longer term management? It's coming as well. And when do we need to refer her to a renal physician? Probably not for many, many years now, as we are going to learn from the next few slides. So in our toolbox for management of CKD, we have 5 options to help the patients. Like I said, ACE inhibitor is the first line. You want to start at a low dose, but push it up to the maximum dose to reduce the amount of albuminuria and to push the eGFR higher. That has 2 advantages, and that's the first one out of our toolbox. Statins, we like statins. The patient with CKD is at risk of cardiovascular disease, 20 times higher chance of dying. So statin is our lifesaver. We like to throw that in particularly in high-risk patients for cardiovascular. Based on the new guidelines, 10% is the cutoff. If they're First Nation people, even 5% cutoff is for starting statins. We need to make sure that when we start statin, their eGFR is above 15, less than 15. We need to ask advice from specialists about starting statins. With or without diabetes, SGLT2 inhibitors are again lifesavers in CKD. They do have all the advantages that we discussed, but for reducing the progression of kidney disease. Again, with SGLT2 inhibitors, we don't like them if eGFR is less than 25. We do have non-steroidal MRAs, which I give you the example of the name. They do have that advantage as well. Again, we don't like them if the eGFR is less than 25, but they do help with the CKD progression if it's associated with type 2 diabetes. So we use them in combination of CKD in the context of type 2 diabetes. Similar rule applies to GLP-1 receptor agonists. Again, if you do have type 2 diabetes, we like to throw them in as well to help with the kidney progression. They are not recommended for use in people with kidney failure, it says. I'm not sure exactly what it means, but I assume it's talking about certain degree of kidney function loss. So going back to the patient that we brought us to this page, when we are going to see, I think it was Mrs. Jones, for review of her perindopril that we started her on, 2.5 milligram, you remember? When do you want to see her? So as you can see, as a clinical tip, if you start someone on ACE inhibitor or ARB, particularly in the setting of CKD, you want to see them in 2 weeks' time. And in 2 weeks' time, you can expect some decline in eGFR. We started it because eGFR is low or was low. And now in 2 weeks' time, we expect the eGFR to go even lower. That's strange, but that's the reality. So initially the eGFR goes low before the eGFR starts going higher as a sign of improvement. So as long as the eGFR hasn't dropped more than 25%, we are okay in 2 weeks time mark. We're happy to just continue with the perindopril and just review patient every 3 months or even longer to increase the dose of perindopril. If the drop in eGFR is more than 25% from the baseline, that is worrying. We need to stop ACE inhibitor or ARB, and we need to refer the patient to a renal physician. That doesn't happen very often, but if it happens, that's a reason to stop and refer. Remember, a similar idea applies to SGLT2 inhibitors in a different way. In SGLT2 inhibitors, we do expect, again, a reversible drop in eGFR around the 4 weeks mark after we start the SGLT2 inhibitors. But unlike the ACE inhibitors that we like to monitor and see if it's below 25% or not, in the SGLT2 ones, we don't have to monitor. We know that if we happen to test, it's going to be lower at 4 weeks time than the baseline. And we know that this is going to go up in the future, but we don't have to keep eye on the eGFR when we start someone on SGLT2 inhibitors. So we haven't forgotten about that woman who we started on perindopril 2.5 milligram. We're going to answer those questions that we asked. But before that, once I've got your attention, I want to cover a few more things. So albuminuria, remember, we said this is even more common sign of CKD, which we like to monitor. With albuminuria, we do have ACE and ARBs and SGLT2 inhibitors and non-steroidal MRAs in the setting of type 2 diabetes to help us to reduce the albuminuria by 30%, which is our goal. So these are the toolbox medications that we have to use. With ACE inhibitors or ARBs, we like to push as high as possible. If needed, we can throw in SGLT2 inhibitors with or without diabetes. If we haven't reached the target and the patient does have type 2 diabetes, we do have 2 more options to throw in. One is non-steroidal MRA, and one is the GLP-1 receptor agonist. They are extra medications in our toolbox that can bring down the amount of albuminuria. So we learned about how to deal with the yellow group patients. Again, no referral usually is needed. Orange ones, they are a bit more advanced because either they have higher amount of albumin in the urine or they have lower amount of eGFR. The goals are still the same. We like to bring the eGFR up and push the albuminuria down by 30%. We followed up these patients more frequently at 3 to 6 months intervals. We do everything that we did for yellow group, but we add iron studies, calcium phosphate levels, and the parathyroid hormone if the eGFR is below 45 in this group. And remember, we still continue searching for underlying cause. So we don't have to stop because we don't have the cause. We just continue with that. The rest is very similar to what we learned in the yellow group. Now we move to the red group. More advanced level of albuminuria, more advanced level of reduced eGFR. In this group, we like to see them more frequently. Majority of patients in this group naturally will fall under the group of referral to specialists, but there might be some categories that we still need to be involved in the care. They need to be seen more frequently. In addition to everything else that we did for orange group, we like to monitor them for edema. We like to, because they are in the red group, we like to even start conversation about advanced care planning. And like I said, majority of these patients will require nephrologist either now or very soon. So let's go back to our patient, Mike. Remember the respiratory physician? We put him properly in the orange group. We started the management with ACE inhibitors and whatever is needed to apply to his care to bring the albuminuria level down and to push the eGFR level up. He says, hey, doc. I mean, he doesn't say doc. He's a respiratory physician. He's going to probably call you by first name. Anyway, he asks you, well, when should I see my renal physician colleagues? Are you comfortable to manage my CKD? You know, I'm a respiratory physician. I'm going to sue you if things go wrong. You know that? He doesn't say that, but let's assume. So we tell him, hey, we have this orange category guidelines in our CKD handbook. We are following the rules. We know exactly what to test, when to test, what to give you, what advice to give you. We know what we are testing to find the underlying cause. As long as the flowchart doesn't recommend seeing a renal physician, you don't need to worry about seeing a renal physician. I'm here to look after you. So when do I need to refer him to a renal physician? This is the flowchart we need to follow. If the eGFR is declining rapidly, and what is rapidly? I love this because it's everything is well explained in here. There's no vague. Rapidly means more than 15% drop over 3 months. Or if they develop oliguria, glomerular hematuria, which we can easily pick up by doing urine microscopy, if they develop acute hypertension or edema, that's a reason to refer even urgently. Any patient with eGFR less than 30, which is a bulk of those red groups, needs to be referred. Or if last year and this year, that within 12 months, results, eGFR shows that they've dropped by 25%, or there is a sustained decrease of 15 mil per year, that's another reason for referral. Patients who have macroalbuminuria with urine ACR of more than 30, which is the cutoff for macroalbuminuria, they need to be referred to renal physician as well as anyone who's got resistant hypertension. Resistant hypertension is the blood pressure that we have not been able to manage with 3 medications at full dose, 3 medications, still not reaching the target. That's the reason to send them to a renal physician. And as you can see in the left bottom of this algorithm, it says continue to manage in primary care. This makes me proud. This makes me proud. We have such a large number of patients with CKD as we discussed in the first few slides. And the recommendation of the CKD handbook is continue to manage in primary care. Such a big load of patients that we can proudly take care of and take the burden off the renal units of the big hospitals and be proud of the profession that we are in. The indication for referral to nephrologist for First Nations people is a bit different. It's on the screen. I'll get you to read later on. If we get to the point of referring to a renal physician, they like us to send the patient with a current FBE, UNE, calcium phosphate, high sensitivity CRP and ESR, the ones that we talked about, and red cell morphology in the urine, and a recent urine ACR to assess the level of proteinuria. We like to have at least one urine, the KUB ultrasound. A recent one may be required, but if we had done one when the CKD started, that might be just good enough. And that's what we need. So if we have those tests done and the flowchart tells us refer, then an early referral is recommended. That was the bulk of CKD management. We covered that. We covered the flowchart. Now we talk about specifically hypertension in CKD because it's slightly different from managing hypertension outside of the CKD. As you remember, in general, if someone has hypertension but not in the setting of CKD or heart failure, we like to start with one of the first-line antihypertensives, go by average dose, then throw in the second-line antihypertensive average dose. If we don't reach the target, then we increase the dose of the first one, and then we increase the dose of the second one. That rule doesn't apply to CKD and hypertension because we do love our ACE inhibitors and ARBs. We like to start with them. We like to push the dose to the maximum tolerated or maximum recommended, as long as we are following the eGFR and potassium, because we know eGFR can go down and we know potassium will go up. As long as it doesn't go beyond the acceptable range of usually 6-ish, we are okay with the increased level of potassium when we start ACE inhibitor and ARB because that is pretty much expected. So once we've done that ACE inhibitor ARB maximum dose, and then if the blood pressure is still high, then similar to other non-CKD patients, you can throw in calcium channel blockers or diuretics or beta blockers. And as soon as you reach three medications and no target achieved, then you can refer the patient to a renal physician. So in terms of the antihypertensive options that we have, ACE and ARBs are first line. We are aware of the 25% reduction in eGFR and the cutoff. We are aware that the potassium can go up and will go up by about 0.5 when we start ACE inhibitors. That's fine. We can tolerate that. 5.5 is the cutoff to start doing things, and 6 is the cutoff to stop ACE inhibitor and again do more things, which I show you in the next coming slides. And we really don't like to stop ACE inhibitor or ARB in CKDs because they are lifesavers. And that's what, as you can see on the bottom of the screen, it says they should not be seized as GFR progressively declines but continued if tolerated. This is the potassium one. So the target potassium is less than 6. As long as we keep it less than 6, we are happy. 5.5 is even better. If it goes above 6, we have measures to take to bring it down in the setting of ACE inhibitor or ARB. We have dietary measures to take. We can throw in potassium wasting diuretics like the thiazides. We can consider giving them some resin or some other medications that can bring the potassium down. If no luck with all those measures and stays above 6, then we need to cease the medication and refer them to a renal physician or potentially to hospital. And 6.5 is the level of worry for potassium. That patient needs to go to emergency if we have a real high potassium and not a hemolyzed sample, because quite often the potassium that you get as high of 6.5 or whatever may not be a true reflection of the real potassium. That can happen with hemolysis as well. So you like to repeat unless you have a clinical concern that this is a real potassium. We can use calcium channel blockers. We can use diuretics in CKD. Loop diuretics are effective in all stages of CKD, and you can keep pushing with furosemide even if the eGFR is extremely low. But remember, the lower the eGFR, the higher dose of furosemide you need to manage the situation. So the lower the eGFR, the bigger dose of Lasix you would need. And yes, it's a common practice to break the furosemide into 2 doses, morning and midday. But as you can see, it says on here that when there is more than 80 milligram required of furosemide, then you have benefit of from dividing into 2 doses. Apparently, from what I understand, is that if the patient is only on 40, there is no advantage in dividing into 2 doses. And thiazides can be effective at even low levels of eGFR to bring the blood pressure down, and you can even mix them with loop like the furosemide. We can use beta blockers in hypertension in the presence of CKD. We can also add in what we called steroidal MRAs. These are helpful in heart failure or hypertension. They are useful in type 2 diabetes and CKD. And remember, you don't want to mix the non-steroidal and steroidal, the non-steroidal and steroidal MRAs together. So the concern we have with the steroidal MRAs is hyperkalemia. So when we combine, for example, spironolactone with ACE inhibitor, we are worried about level of potassium. We need to monitor it. We need to make sure patient is on low potassium diet, and we need to take any measure. For example, adding a potassium wasting diuretic to make sure the potassium level stays low. This is about triple whammy. You are aware of triple whammy, which is the combination of a diuretic, an ACE inhibitor or ARB. Generally, they call them RAS blockade, and NSAID or COX-2 inhibitor. We know that this combination in anyone increases the chance of kidney failure. And if someone already has CKD in the background, the chance of developing acute kidney injury is even higher. So we don't want to mix these three medications together. And remember, even though aspirin is an NSAID, the low dose 100 milligram aspirin that people take every day for bowel cancer prevention or for cardiovascular disease doesn't count as an NSAID. So you can continue with that plus, diuretic and an ACE inhibitor or ARB. So we see this question a lot in CCE, in AKT-KFB. The patient is on triple whammy and they want your eyes to be fully vigilant of these three combinations. And as soon as you see the three of them in one patient, you want to stop at least one. Diabetes and CKD, another topic. Many of the diabetic patients develop CKD. Many of the CKD patients may develop diabetes. We do like some medications, some diabetes medications more than the others in the setting of CKD. Look, metformin is good for any diabetic patients anyway. So it doesn't have specific advantage for CKD, but it does help a lot with the diabetes. So that's a must continue medication as long as the eGFR allows. And you can see on the screen where is the cutoff for worrying about eGFR or worrying about metformin in the setting of the eGFR. SGLT2 inhibitors, we love them because they have kidney benefits. They also have cardiovascular benefits. We are worried about them in case of developing euglycemic diabetic ketoacidosis. So that's why as soon as the patient is at risk of dehydration or is going for an operation or fasting or sick, and we like them to stop SGLT2 inhibitors. We don't want to take that risk of euglycemic diabetic ketoacidosis. All of them can be used for the kidney advantage, the dapagliflozin, empagliflozin, and ertogliflozin. And kidney function for all of these need to be monitored because at certain levels of eGFR, you need to either stop or reduce the dose. Non-steroidal MRAs in the setting of diabetes and the CKD have advantage. So you need to have both of them, both CKD and diabetes, to benefit from non-steroidal MRAs. Again, there's an eGFR cutoff for them, and the one that is available in Australia is the one you can see on the screen. Kerendia or finerenone is the non-steroidal MRA with advantage in CKD with diabetes. The next one is the next set of medications. We have DPP-4 inhibitors. They're all good, again, in diabetes, not necessarily kidney advantage, but they can be used. Linagliptin is the only one that doesn't have any eGFR related dose adjustment. The rest need dose adjustment. So probably that's the top of the list in the setting of CKD. With the sulfonylureas and insulin in the setting of CKD, we can still use them, but we need to be more cautious of the potential risk of hypoglycemia with those two medications in CKD. And GLP-1 receptor agonists, like we discussed earlier, they do have kidney benefits similar to the SGLT2s, and they also have cardiovascular benefits as well, particularly in atherosclerotic disease and to some extent in heart failure. So next step would be sick day drug management. Anyone with CKD, they need to be aware of the SADMANs. SADMANs are the group of medications that anyone with CKD, if they are at risk of dehydration or if they are sick and they have reduced oral intake, they need to avoid SADMANs. Sulfonylureas, ACE inhibitors, diuretics, metformin, ARBs, NSAIDs, and SGLT2 inhibitors. Some of these need to be avoided because they cause decline in kidney function, like ACE and ARBs, NSAIDs, and diuretics. And some of them need to be avoided because they can cause other complications, like metformin can cause lactic acidosis, sulfonylureas can cause hypoglycemia, and SGLT2 inhibitors can cause euglycemic DKA. Next quick topic would be microscopic hematuria. We do diagnose a lot of microscopic hematuria in general practice when we order MSUs, or ideally, when you order MSU, quite often the labs do the dipstick test for you as well. Either we do the dipstick or the lab does dipstick. If there is some blood found in the urine dipstick, that's good enough to start investigation for hematuria. If hematuria is found on dipstick and then is confirmed on microscopy, that's another difference in the new guidelines. In old guidelines, they were saying you only need to stick to dipstick for urine microscopic hematuria and never do microscopy. Whereas now they say it's more in line with American guidelines and the rest of the world guidelines. They say if you find microscopic hematuria on dipsticks, then the next step would be confirming it with microscopy. And if it's still there and it's persistent over time with a few repeats, then you need to start investigating the cause. One step would be doing an RBC morphology to see if it's a glomerular hematuria, which is more in favor of a kidney source, which then requires considering potential glomerulonephritis. You need to do an ultrasound, and you need to send the patient to a nephrologist if they have glomerular persistent microscopic hematuria. If the hematuria is microscopic and persistent and non-glomerular, that's concerning for most likely urogenital malignancies. Bladder cancer more than anything else, but also kidney cancer or any other cancer in the urogenital path, including, for example, prostate cancer. So what do? We know that many younger patients may have some persistent microscopic hematuria without any sinister underlying cause. So our job is to see if the patient has risk factor for a cancer, a malignancy, or not. If they do, next step would be urine cytology, repeated 3 times, imaging with an ultrasound, and regardless of the results, referral to a urologist for cystoscopy if nothing else found so far, if they have risk factors. What are the risk factors? Anyone over the age of 40, anyone who has history of macroscopic or gross hematuria, which should have had referral to specialist earlier anyway. I don't know why they haven't been referred yet. Someone has done not the right job, or the patient decided not to show up. Either way, it's not acceptable. Any smoker, anyone with the history of pelvic radiation or irradiation, anyone with occupational exposure to chemicals, dyes, and cyclophosphamide is considered high risk for malignancy in the urogenital tract. And after doing urine cytology for 3 times and ultrasound, they still need to be referred to a urologist. If they don't have any of those risk factors and they have persistent microscopic hematuria without any of those risk factors, it's okay to just monitor them annually and doing those tests, including the imaging and urine tests. And if everything is fine, we can see them again in another year until they grow over age of 40. So this is a test or an MCQ, first step and further assessment of microscopic hematuria found on urine dipstick. Nowadays is a formal microscopic management assessment of urine plus an RBC morphology. Another case, Chiara, 30, persistent microscopic hematuria. She's had urine MCS. She's asymptomatic. She's had ultrasound. Everything has been done, is normal. She doesn't have any risk factors for urinary malignancy. She's otherwise fit and healthy. And this urinary microscopic hematuria was found as part of the pre-employment assessment. In this case, she would be a fit one to just follow up annually based on our CKD guidelines. So with the hematuria part, first thing is just to find the potential cause. Might be stone, might be contamination, might be urological like we discussed, might be prostate related, or it might be a tumor cancer, which falls under urological. If it's visible, if someone comes in with gross hematuria, as long as we make sure it's not UTI, because it's not unusual for a UTI to present with blood in the urine. So if it's not UTI, or if you have any concern about malignancy, that is by itself an indication for referral to a urologist. Don't sit on gross macroscopic hematuria. That's a crime, right? If we suspect that this is a glomerular disease, we know what to do. We talked about the steps to take and the risk factors. And we like to do the microscopic confirmation of dipstick's findings. And depending on glomerular or non-glomerular, we learned what we need to do. But in terms of Chiara, who was our patient, as you can see on the right box, persistent microscopic hematuria should prompt investigation for urinary tract malignancy in certain groups. If no malignancy and it's not mixed with, if it's mixed with albuminuria, you need to refer. If it's not mixed with albuminuria and you're comfortable that nothing else is going on, annual repeat screening is also acceptable. But anytime you have mix of protein and blood in the urine, you need to refer to a renal physician. This is just a reminder, a list of causes of hematuria. It's not from CKD guidelines. It's just to remind you what can give you the hematuria in the urine. And these are the same things, just in a picture format. So for hematuria part, we have a 67-year-old gentleman who was found to have albuminuria and hematuria. What do we do with him? Remember, blood and protein. That's it. We don't need to look at anything else. He needs to be seen by a renal physician because he has both blood and protein in the urine. That's concerning for glomerulonephritis or any type of kidney disease. He needs to see. We still do our pre-referral investigations, don't take me wrong, but he needs a renal physician. This one is a 52-year-old with no proteinuria, but just 2+ hematuria. We've excluded the MSU and cancer, an infection. He's a smoker. We've done an RBC morphology, which is non-glomerular in favor of urological malignancy or in concerning for urological malignancy. What steps? We know that he needs to see a urologist for cystoscopy, but being a doctor, we like to do the initial workup because we may find the exact diagnosis before we send him. That's why we do an ultrasound, because ultrasound may show a tumor in the kidneys or anywhere else in the urinary tract. We need to do a urinary cytology because that can assist with the specialist, the urologist, with the further investigations. And if we find something, we send the patient to urologist with an answer. We say, this is the patient I'm referring to you with the renal cell carcinoma. Or we say, this is a patient with hematuria, which I have done this and this and this, and cleared everything else, and he would benefit from a cystoscopy, and then we refer them to a specialist. One more emphasis on gross or macroscopic hematuria. You exclude UTI, but most times you need to refer them to a urologist for cystoscopy. Just a few examples of imaging shown bladder cancer. This is a bladder cancer. The filling defect that we see is a bladder cancer causing hematuria, macroscopic or microscopic. This is a renal cell carcinoma. The patient presented with, again, microscopic. He was diagnosed, or she was diagnosed with microscopic hematuria, and then eventually led to diagnosis of RCC. Another one in a CT. This is a CT KUB. Ultrasound still is good enough for picking renal cell carcinoma as well, or any urogenital malignancy. So that's done, the hematuria. Hyperuricemia is something that we see in patients with CKD, and also it has some common triggers and risk factors with cardiovascular disease and the CKD. So this tells you about what food they need to avoid: beer, seafood, organ meat, fructose, fructose which can be found in fruit, honey, sugar, and high fructose corn syrup. We know that it has, what else? Talking about uric acid, is associated with hypertension, gout, non-alcoholic fatty liver disease, CKD, and cardiovascular disease. We only start allopurinol in the setting of gout, acute gout. If they don't have acute gout, we don't just use allopurinol to bring the level down. If they do develop acute gout, and then we need to start allopurinol in the CKD setting, we like to start at low dose of 50 to 100, and we like to be more gentle with increasing dose of allopurinol because of the kidney function problem. Colchicine can be used, but with caution in CKD, and in certain levels of eGFR, as you can see on the screen, we need to adjust the colchicine because that can cause damage to the kidneys. Next topic is kidney stone. Again, covered briefly in our CKD guidelines. We start by one case of 44-year-old gentleman with a 4 mm stone found in VUJ on X-ray KUB and then the CT scan. And he is referred to us as his competent GP to take over the management of kidney stone, which we should be able to do. So what do we do with him? He's been given pain medications. He was told, hey, you have a stone of 4 mm, you have a good chance of passing. Go to your GP and he or she will take over from here. What do we do here now? So apart from making sure he's got good pain management in place, apart from making sure he is on some alpha blocker, ideally tamsulosin, and apart from the recommendation to catch the stone if he can with a sieve or by straining, we also need to make sure that he's had certain blood tests done for uric acid, for calcium, for oxalate level in the urine, which I'll go through in a few minutes. But in terms of stone management, our job is to repeat his either CT KUB or X-ray KUB if the stone was visible on the X-ray, which in this case was. We can repeat the X-ray in 4 weeks' time to make sure the stone is passed. This is the stone that you can see on this CT KUB on the right ureter. This is another stone in the right ureter, the other view. The gold standard for diagnosis of urinary stone is CT KUB, full stop. Ultrasound can be done, doesn't have the same sensitivity, but can be done. If you can't use radiation, for example, in pregnancy, remember CT KUB has no contrast, so we're not worried about contrast. It's a non-contrast CT. Ultrasound we only use if patient cannot get radiation, or, for example, in a younger woman that we still not 100% sure, we like to have a look at the ovaries, we like to have a look at the internal organs to exclude other causes, which can be seen better by ultrasound, then ultrasound is potential alternative. But in majority of patients, which is more likely to be a middle-aged to older men with kidney stone, CT KUB is the way to go. And once we do CT KUB, if we want to be too nice or nice enough to the patient, we can also order an X-ray KUB, which is simpler, cheaper, less radiation at the same time. And if the stone can be seen on X-ray as well, not all the stones can be seen on X-ray, then in 4 weeks' time, instead of repeating CT KUB, we can just order a X-ray KUB to prove that the stone is gone. So another case in emergency, someone is coming with potential ureteric colic or renal colic. Quick questions are, what do you want to give to a renal colic patient now in emergency, immediately? Second question is, what investigations you want to order in addition to your CT KUB in a patient of renal colic? Third question is, what are the reasons to send a renal colic patient to specialists right away instead of just pain management and investigations? And four, which is a lot more important to us as GPs, what lifestyle and diet factors the patients can introduce into their life to reduce the chance of developing further stones, because many patients would come back with another stone sometime sooner or later. And apart from stone prevention advice, 5 aspects of his management at emergency discharge. So what do you want the patient to do when they go home from your rural emergency, for example. Answer to question 1, the best painkiller in renal colic is NSAIDs, because not only they can help with the pain, but they can reduce the filtration and the pressure behind the stone, and they are your best friend in renal colic. On top of that, you can add the opioids. You can give some metoclopramide, because many of these patients can be nauseous as well. In terms of investigations, we like to do CT-KUB, gold standard. We like to do UNEs to check for kidney function. We like to check the urine for blood, which most likely will be there in the setting of kidney stone, but we don't want to see infection. We like to check calcium, because kidney stone may be the first presentation of hypercalcemia, which may be caused by hyperparathyroidism. So we like to check the calcium. Kidney stone can be a sign of gout or hyperuricemia, so uric acid level is a must. We like to instruct the patient to strain the urine and catch the stone if they can, because the analysis will help us to prevent or put a better prevention plan for the future stones. We like to do 24-hour urine collection for calcium, oxalate, citrate, and uric acid in the urine, again, for helping us with the prevention of stones in the future. And like I said, X-ray KUB is a potential additional option. Reasons to worry about a kidney stone patient in emergency setting: sepsis, renal failure, pain that you can't control, urinary obstruction, patient with only one kidney, and patient with pre-existing kidney disease or a stone which is above 7 millimeters size. The chance of passing is low. Why the patient should suffer? You want to get the specialist involved. Not urgent, but you want the specialist, in this case, involved sooner than later. More important one, what diet advice you have for the patient? In terms of hydration, definitely the recommendations are different. The latest CKD guideline 5th edition says 2 liters of urine output a day. Doesn't matter how much intake, you need to measure the output, because if someone is working in a tropical environment in summer, they're very hot and sweaty and they're physical, they may lose a lot of water through sweating. So what counts is how much urine you pass, and 2 liters is the goal. Some other references, like the AJGP article, says if the urine is clear all the time, that's a good sign of enough hydration as well. You want person with kidney stone to reduce sodium, reduce protein intake, particularly animal protein, reduce oxalate intake, and have a normal calcium intake. We don't want them to avoid dairies. We like them to have a normal intake of dairy. Not too much, but not too little either. Acute management: NSAIDs, tamsulosin, paracetamol, straining the urine, and return to emergency if any problem with sepsis or whatever that we mentioned as red flags, and repeat usually in 4 weeks' time of CT-KUB by your GP. This is pretty much all we said about the dietary advice and the medication to use. This is a summary of everything on the 5th CKD guidelines. And these are the images and slides from other references like AJGP or therapeutic guidelines about what we discussed already, nothing new, but just I want to make sure you understand where my words come from. It's never from Sol, it's from a reference and an Australian valid reference. But these are just an extra information about managing kidney stone in rural emergency or in the general practice setting, and how to decrease the chance of developing more stones. They're all here for your use. And I believe that oh, no, it doesn't. I have 1 more or 2 more topics to talk about before we wrap up. Kidney cysts, very common, very common. 10% of people, when we order kidney ultrasound, we see kidney cysts. Asymptomatic majority of them. The older the patient, the higher the chance of having a kidney cyst found on the ultrasound or whatever investigation you order. And they don't usually cause kidney failure, so you don't need to worry about them. The only reasons to worry about kidney cysts are the following: multiple kidney cysts in either one kidney or both kidneys, Cysts which are complex in nature, which means they have complex internal structure or solid component. History of malignancy. Symptomatic cysts like discomfort, hematuria, infection, or a rapidly enlarging cyst are the reasons to start worrying about a cyst. Polycystic kidney disease is covered in CKD guidelines. Usually, if you find them on the ultrasound, we will refer the patient. But where is the cutoff for finding multiple cysts and thinking about polycystic kidney disease? In younger people under age of 40, 3 cysts in total is a reason to start considering polycystic kidney disease. Between 40 and 60, 2 in each kidney, and over 60, 4 cysts in each kidney is the cutoff to start worrying about polycystic kidney disease and referring to specialists. And the very last one is about use of contrast in CKD. In someone who we have diagnosed CKD and labeled in the records, we always have a bit of a concern about radiologic contrast or radiographic contrast. And this is a topic that always changes. So take home message, if the eGFR is more than 45 and the patient is well hydrated before and after contrast, the risk is negligible. So a eGFR of over 45, you can comfortably order a CT or imaging with a contrast. Between eGFR of 30 and 44, the risk is intermediate. And if the patient also has diabetes, the risk is even higher. And eGFR under 30 is the one that you really don't want to give contrast unless you have recommendation or advice by someone else, like by a specialist. And that was it. I hope that you enjoyed the CKD guidelines learning, put it into your practice, and enjoy giving the best care to your patients in your practice. Thanks for listening.